This virtual meeting provided us as partners in health and wellness an opportunity to collaboratively plan, facilitate and communicate to improve rural access, quality and efficiency in order to create a healthcare system legacy extending and learning from the disruptive changes of COVID-19. Over 950 people attended at 57 community tables across British Columbia. These answers were part of the virtual speakers corner attendees volunteered to participate in after group sessions.
And for me, the first thing is really about community engagement. And so we as health administrators or as physicians think we know things, but we don't. And we don't know anything more than what the patients tell us. And so the prospect of storytelling or going into community and asking people about their stories, both historical, cultural, and then real lived experiences, should be what shapes and forms our healthcare system. And so when I'm talking about virtual care, talking about outreach programs, I have an idea of what the community needs, but I think it's critically important for our rural and specifically our Indigenous communities that we go out into community without agenda, that we go out into community without a thought about what needs to happen there. It's not us and them, it continues to be we. And so it continues to impress upon me as we sit around the table virtually this morning that we collectively need to design our system better and different. And through COVID and through the whole pandemic in the last 3 months, we have been able to do some nothing short of miraculous things, and we continue to need to do that for the sake of our communities, both rurally and Indigenous. The second thing is really about how, and so how we go about implementing services. And so I had a robust conversation with the community paramedic program earlier, just before this, in fact, about how we can help each other do that. And so the community paramedics work in rural communities already. They're there, their hands and the feet on the ground. I have a privilege in Anderson Creek or Boston Bar to have a community paramedic, and I think I probably underutilize him. And so we need to layer upon what we're doing well already. We need to give ourselves the opportunity to provide better patient-centered care, which includes both what the physician can offer, but also what the other team members can offer. And when we move forward together and we provide the sort of services that patients and communities tell their stories about, and we can then do that, then that's the kind of transformational change that I will think and expect to occur from what's happened already, but also moving forward.
Our group really felt that cultural safety and humility were really the priority of the day. And I think as Dr. Marquis, one of the primary care physicians in Prince George, stated so well, our healthcare system can be really nimble and adapt, much as it did in COVID-19, if we put priority on something. And rightly so, we put priority on the pandemic. And perhaps really the next healthcare crisis that we need to address is that of ensuring culturally safe care to really better health inequities and to make a change so that we really are ensuring people have access to culturally safe care. If we put priority on this, then we can all do our part to make that change. And I think if there was, again, sort of priority pieces or actionable pieces that we felt would facilitate that vision and that dream, it was to make space and to make time for and make safe space for the heavy lifting that we as healthcare professionals and as academics and educators like myself need to do to actually start to examine where those points are along the healthcare journey for Indigenous people that we can address. We need to do that heavy lifting. If we talk about Dr. Aldred's 5 R's, responsibility is one of the key components of that, to be able to say, I recognize my biases. I recognize where I may, in fact, be creating obstacles in the system that don't allow for that relationship, that longitudinal relationship that we know is so important for when individuals come from community into tertiary centers. And how do we, in fact, preserve that relationship in the long run. We talked quite a bit about how the current training environment may be addressing future healthcare professionals in terms of Indigenous cultural safety, and potentially those that are already in the system who are already mindful of the need towards culturally safe care and being humble. Those are the ones taking the courses. Perhaps where we need to work harder is to create safe spaces that can bring in mentorship, can bring in coaching, can bring in consultation and facilitate those difficult conversations. We talked about partnership with Indigenous elders or folks who feel comfortable being in that consultative role, and really making space for that in our busy days. But again, if we put this as a priority, then perhaps we can make that happen. Part of that conversation was also around really the need to start to kind of shift the culture in the work environment, where many of us who are part of these tables already and engaged in this kind of work can perhaps step up a little bit more and be accountable by calling out where we see racism actually happening, and make a difference by speaking out, that we have certainly a big role to play in that. And perhaps that in turn can also change the system. So I think in terms of action statements, we really felt strongly around the importance of being advocates ourselves, by again speaking out, by also ensuring that we're creating those safe spaces for the learning to happen. We're creating learning organizations that can foster and support others in their learning journey towards culturally safe care, and then working with individuals and communities, in particular Indigenous communities, to provide mentorship and coaching for those healthcare teams who again want to examine that.
Two things I'd like to share that stood out to me about what's currently working in regard to access to care, quality, and efficiency is that we're listening to our community members and colleagues across our community. So as a co-chair of the Hope and Area Healthy Communities Committee, I've already learned a bunch of things today that I can bring back to the group. And as a member of an academic community, I've learned things to bring back to my home institution, and I've really appreciated the humility and willingness to be corrected I've witnessed within the group work, and it makes it a lot easier to model and then learn and then model for someone else what I've learned. So thank you to everyone.
So the first thing that stood out to me, even when I reflect back on the last 2.5, 3 months through COVID, is the virtual care, and really how well it has been working in regards to like prescription renewals. And when I think of virtual care, it's, it works really well for some things and some people, but it doesn't work for everything and everyone. One thing that stands out for me in virtual care when all of this first started is we were setting up the geriatric team to come to our community. And then of course they weren't going to attend in person because of COVID. So then how are we going to get these 10 people that we had already lined up for appointments seen? And what was really interesting is our first group of 5, only 2 agreed to still see the geriatric team. Because, there was a variety of challenges. Either A, I don't have the technology in my home, or B, even with us saying, well, come to the clinic, we have it here, we'll support you, there'll be a nurse that attends the appointment, we'll be wearing masks. They would have nothing to do with it because no, we are told we're to stay at home. And we even tried to address them with our seniors. Could someone attend your home? We'll bring the laptop, and we want to ensure that you still can access the geriatric team. And of that, we only had 1 that agreed to. But this also got us thinking, okay, how can, moving forward, there are so many people that cannot access care for a variety of reasons, certainly in-person care as well as virtual care. So how can we look to ensure that they're still able to access this. You know, if there was something I could wish for, what could it be? So we thought, well, okay, a couple of iPads, and then this would help our team go out to people that needed to connect with their primary care provider. If we're thinking of the whole purpose of this summit and working with our First Nations communities, this was another challenge that we faced, is the providers themselves were removed from the two communities, so both in Stellarton and Nodeley, which then left us to, potentially either have the people come to the clinic, which is absolutely a non-issue if they need to be seen in person, but then we also had people in the First Nations communities that weren't able to come to the clinic, so now we had to go to them. It ended up just being a nurse going out and doing the assessment on behalf of the provider, but it just identified, okay, this is great. If we get these iPads, we can use them in the community. We can, hopefully connect some of the clients with their providers if they have the internet capability. The other thing that, again, we were talking about virtual care and addictions and overdoses in the first group that I was in, and I just reflected and shared a story from our mental health clinician that she had been counseling. There was actually 3 people that came to mind almost probably within 2 weeks of us connecting virtually with everyone, and she said that was what was really interesting, is she felt that she made more headway with the counseling doing it virtually. So then, you reflect back on, well, they're in their own home and maybe more comfortable and more receptive, more open. Anyways, it was a nice win to hear that we're offering the service in a different manner, but she felt that it actually was more productive and the client, benefited better from it.
The top 2 things that stand out to me about what's currently working would be the impetus that COVID has provided us to use technology to improve access to care, and also the impetus that it has linked us to other parts of the province that we never would have been able to talk to, and so exposure to different models of care, transportation, or whatever, different ways of accessing care. And so we've had increased collaboration. The second thing would be the recognition and now the possibility to use technology to interact with our communities more and find out what communities and community members need in terms of access to care.
I think some of the things from this morning's session that were good was really getting some supports in as well to make sure that we have culturally safe care, to minimize the needs for transportation, but make sure that we have transportation available when we need it, to try to keep our seniors in our community and at home as long as possible, and so making sure we have the supports for that.